Thank you, Nicola, and hi, everyone. Such a great pleasure to welcome you all to this third ICMLF-hosted CML discussion in Africa, this time shining the light on challenging scenarios in treating CML. Okay, so what a great team of experts we have to lead the conversation today. I'll start with our two international experts, and it's a great pleasure, hopefully he's here now, to introduce Professor Giuseppe Saglio from Italy and Professor Naeem Chaudhri from Saudi Arabia. So Professor Saglio, or Beppe, as he's better known around the world, is a global giant in CML. He's on the board of the ICMLF. He's a champion of our knowledge center, which I hope you all visit often. And as well as being a great hematologist, he is a force of nature. He's a great traveler, wonderful company, and hopefully you have joined us by now in the audience. Beppe, welcome if you're here. Professor Naeem Chaudhri is, of course, preceded by his reputation. He is a professor of medicine and leading consultant hematologist in the King Faisal Specialist Hospital and Research Center in Saudi Arabia. Naeem, it's a real privilege to share this platform with you today. Welcome. Our African experts today are firstly Amha Gebremedhin, Associate Professor of Medicine and Consultant in Internal Medicine and Hematology at the School of Medicine at Addis Ababa University. Amha is on the ICMLF's African Steering Group. He's a contributor to our Knowledge Center, providing a very insightful presentation on treating CML in resource-constrained Ethiopia. Welcome, Amha. It's an honor to have you here with us today. And our fourth expert today is Dr. Olanrewaju Ochogwu, who has just started a year's placement in the clinical hematology section of cancer care in the University Hospital Southampton in the UK. But she's much better known to us in the foundation as a leading CML physician from Nigeria. I first got to know Lanre when she was a preceptor and she was hosted at the City of York Hospital in Los Angeles. And since then, she's been a great contributor and supporter of the foundation. Lanre is also on the foundation's Africa Steering Group. Welcome, Lanre. Such a pleasure to share this platform with you today. So we have a packed schedule. We have 7 cases ready to go that exemplify a whole range of challenging scenarios. Amha and Lanre will alternate with each other, presenting their cases, and Beppe and Naeem will respond, and all 4 experts will discuss the challenging scenarios as they arise. We are sticking to 10 minutes per case because we've got so much to get through. So fingers crossed, we can be good and efficient. If we don't get to questions during the case itself, hopefully we'll have a chance to come back afterwards. We will start with Amha's case first.
Hi, everyone. Thank you. So I will start with the first case. Actually, this is a new patient that we have seen recently. This is a 24-year-old male who presented with fatigue, anorexia, weight loss, fever, and abdominal distension, particularly left upper quadrant discomfort of about 6 months duration. Physical exam in this patient was remarkable for moderate pallor and sternal tenderness. The liver was about 4 centimeters palpable below costal margin, and the spleen was 6 centimeters. Lab data included a hemoglobin of 7.2 grams per deciliter. The white cell count was 139,000 with a differential of 49% neutrophils, and he had 31% myeloblasts. The lymphocyte percentage was 8, monocytes for the baso was 6%, and the eosinophil was 2%. Platelets were 123,000. Bone marrow was hypercellular with a myeloid-to-erythroid ratio of 10%, which was flooded by blasts. So the report of the pathologist was blast-face CML. Biochemical studies were normal except for the lactate dehydrogenase of 560 and uric acid level of 9.6. The BCR-ABL fish was 100% positive. So as you can see, this is a patient with high risk. Euroscore long-term score, which is high in this patient. So this is a patient who has de novo chronic, blast phase CML. So the questions are, in this patient at presentation, are additional tests required before the initiation of treatment? The next question is, what is the optimal approach to the treatment of this patient?
Thanks so much, Amha, for that interesting case. Beppe seems to have become delayed somehow. So, Professor Naeem, would you please care to lead on this case?
Sure. Thank you very much. This is a nice case, and we do encounter some of these tough cases. Although de novo myeloid blast crisis is not that common, usually patients do present with chronic myeloid leukemia and sometimes untreated, and they wait and wait and then eventually turn into blast crisis. So the question number one is, are any additional tests required? I wanted to know was there any mutation analysis done, because this patient will certainly require treatment as an acute myeloid leukemia. There's no question about this. It's an acute myeloid leukemia. So an acute myeloid leukemia treatment has to be there, along with the addition of a tyrosine kinase inhibitor. And it will be fruitful to know what is the mutation. Although ponatinib is there, which can cover almost all mutations, and all of them are sensitive to ponatinib. But just for the sake of clarity, the mutation that one can follow after the treatment also. So that is number one. Number two, test that may be sometimes helpful, not necessarily for the selection of the treatment, is an NGS, next generation sequencing, because as you all very well know, that almost like 40% of these myeloid blast crises or myeloid malignancies or de novo, or even in the one that turns into blast crisis from chronic myeloid leukemia, the driver mutations are common. Like, for example, RANKS1 is almost positive in 40% of the patient. And some of the patients have AXXL1 also, which are also considered to be very high risk. So that would be NGS would be another test that would be beneficial to have a baseline. I think these are the two that probably would be beneficial, other than the fact that you have already done the fish as well as, I'm sure, the bone marrow. I don't see the G-banding analysis of the chromosome analysis. Sometimes the double Philadelphia or the isochrome 17 or some other additional chromosome abnormalities also indicate a high risk, or the patient has already converted into a blast crisis. So do you have any comment? Do you have those tests, or should we go to the treatment approach, Amha?
Thank you, Professor. Unfortunately, we don't have, for example, cytogenetic studies, chromosomal analysis in our center. And we depend on fish or molecular studies, including PCR only, for the diagnosis of CML. So unfortunately, we don't have really chromosomal, and we cannot do chromosomal analysis in our center.
Okay. So that means the NGS probably also would not be available if the chromosome analysis are not there. Yeah, so they're expensive. So for the purpose of the treatment approach, the second question, what is the treatment approach? There is certainly no question this patient number one requires to go into a remission. Although you can give this patient, for example, ponatinib initially at a 45 milligram per daily, that can put some of these patients into remission. But as a general overall management consensus is concerned, it usually is a combination of acute myeloid leukemia chemotherapy, that is whether 3+7, either ribociclib or cytarabine, or whether it's ribociclib or cytarabine, along with the TKI. And in the absence of any mutation, which we don't know, I would use something like ponatinib, which overcomes all mutations to get the patient into remission. Although you could make a case that you could go with imatinib or dasatinib with it. But in the absence of mutation, and he's a young man, and the objective is to get him into some sort of remission, genetic response, or a molecular response after the chemotherapy, plus tyrosine kinase inhibitor, and then take him to transplant. If he has a matched sibling donor, even if he does not have a matched sibling donor. the outcome with haplo stem cell transplant are equally good and safe now with the post-transplantation use of cyclophosphamide. So my approach would be to treat him as an acute myeloid leukemia with tyrosine kinase inhibitor and chemotherapy, and then take him to allogeneic stem cell transplantation.
Thank you. Can I just maybe 1 or 2 pointers? What we do here is in this situation, when you have a blast crisis at presentation, de novo blast crisis, we usually start by the way, the only medications we have in our center are imatinib and nilotinib. Imatinib is obtained through donations, and therefore we start usually higher doses of imatinib in this kind of patients, and we try to bring them back to the chronic phase of CML. Then subsequently, depending on response, we may continue on imatinib or consider second generation TKI. Otherwise, it will be very difficult to consider chemotherapy in these patients because the setup does not allow you. And from our experience, many of these patients actually come back to the chronic phase of the disease.
That is certainly, this may be one way to go also. Patients do respond. The only drawback is that most of the patients eventually in 3 to 6 months will relapse and become resistant. And so if you have a matched donor for them, then it's better to get them into remission and then take them to transplant. Now for only TKI, I think imatinib is perfectly fine at a high dose, 600 or 800 milligrams daily if you do not have the approach to chemotherapy, and then continue that patient, and they can go into remission, but almost all of them will relapse somehow in around 6 months. That's what has been published from the other centers, as well as the retrospective analysis that has been published also. So if there is no chemotherapy available, then certainly only TKI can be used to get them into a chronic phase 2 and then take them to transplant. Did you have a transplant facility available there?
No, not yet.
That was a great discussion, and there's clearly more fodder in there. But as I said, I will be the time police in this instance. But hold on to any other issues, questions, etc., discussion. Let's try and come back to that at the end.